Hello everyone, my name is JD Cochran, current supervisor here at the Piedmont Atlanta Echo Lab, and today we are going to present a PowerPoint presentation to go over and discuss the new stress echo protocols that are coming for Piedmont Healthcare as a system. I have no disclosures currently. So the objective of the presentation is to review the new stress echo protocol that's going to be being presented across the Piedmont Healthcare system, and hopefully have any questions or answers. I would then defer you over to myself, your technical leads for each entity, or Teresa Green, our system educator. So Piedmont Healthcare Stress Echo Protocol, what we have decided to do as part of the COE task force is create protocols to unify the echo labs across the Piedmont Healthcare system, so that way, regardless if a patient gets an echo done down at Henry, Fayette, Atlanta, Athens, essentially the patient's getting the same quality exam as well as following the same protocol. So the major changes compared to probably existing protocols are changing the dobutamine stress echo for ischemia to a 4-stage exam. This is 4-stage exam for both acquiring images. So we're acquiring images rest, low dose, peak, and recovery. The nursing dose administration for Atlanta has changed and will be the same across the system, and we'll start with administration doses of 10 mics. Then after 3 minutes we'll increase to 20 mics, and then 3 minutes 30 mics, and then 3 minutes 40 mics. Somewhere between the 30 and 40 mic phase, nurses can be giving atropine if the heart rate does not show an appropriate response to the dobutamine medication. The other big change for the exercise ischemic protocol is we will be changing that to a 3-stage imaging acquisition. The 3-stage imaging acquisition will walk through some cases, but will be baseline as normal. We'll also do our peak as normal, but then we'll be adding a recovery images of the LV. In addition to the exercise ischemic stress test, we will be adding a diastolic stress test to all exercise ischemic workups. Here to the right, you can see a snippet of the actual Piedmont Healthcare stress echocardiogram protocol. The stress echo protocol will eventually be located on the village. Majority of all of our protocols and policies are slowly being implemented and applied to the Piedmont Village policies. So here's a snippet of the village. If you see the tab there under policies, you would go to policy stat and log in using your individual credentials and password. So let's look at an example of the exercise stress echocardiogram. So for all stress echocardiograms, whether it is a ischemia for exercise or ischemia for dobutamine, the first thing you're going to do is screen for contraindications. So these contraindication screenings must be performed in a patient who has not had a previous scan within the Piedmont Healthcare system for prior to 1 year to date. Also, if an echocardiogram was completed somewhere outside of the Piedmont Healthcare system, but the images are not available for review, we would need to then go ahead and use the screening contraindications protocol again. What that entails is starting off on an apical first for chamber with no color, essentially assessing wall motion and global function. From there, you'll color the mitral valve, looking for any new signs of significant mitral regurgitation, flail leaflets. From there, we'll also color the tricuspid valve, again looking for any significant tricuspid regurgitation, problems with the tricuspid valve that are unknown to us. We'll then CW the TR for a peak RVSP velocity, as well as then looking at the apical 5 with color, looking at the aortic valve, ensuring that there's no significant aortic regurgitation or any sort of aortic pathology. We'll CW across the aortic valve to measure a mean aortic valve gradient, ruling out any contraindications of aortic stenosis that may be unknown to us. From there, we'll look at the peristernal long axis, assessing the aortic root and the ascending aorta, making sure that there's no dilatation or dissections that were unknown to us, and also measure the LV internal diameter as well as wall thickness, both in diastole and systole. If something were to come up abnormal in any of these contraindication screening studies, I would defer you to consult with your reading cardiologist for the day or week, however your entity is set up, to ask them for further advice on whether to proceed or additional images may be needed. So the baseline is moving for the stress echo for exercise. These are baseline measurements that are needed for every exercise stress echocardiogram, but not for the dobutamine stress echoes. And essentially this will be starting our diastolic workup. So we'll measure a biplane LA in systolic volume, as well as a PW of the pulmonary veins. So these two measurements and the contraindication screening measurements, they should all be done outside of the protocol before you actually start your protocol on the machine. Now, moving to the resting images. The resting images should be built into your machine as part of the protocol. I would highly encourage you to reach out to your vendor-specific applications person to assist you in building the protocols. In doing that, also I would highly suggest, once you have built your protocol, to test it out a few times on a said dummy patient, or just testing the workflow of it before you actually proceed in scanning a live actual patient, so that way you can work out any kinks or bugs that you may not have anticipated. So first images, you start off on the resting for LV ischemia, and the exercise stress echo protocol is the diastology workup, which would start with a pulse wave of the mitral valve inflow, looking at your E and A, as well as your deceleration time. Following that, you would like to PW the tissue Doppler LV lateral and medial annuluses, measuring your E prime to then calculate your E to E prime ratio. From there, you would then, if you have not already done it, but in the package, CW the TR peak velocity as well. And then once you've done those, you're going to move on to your standard LV images, starting with an apical 4-chamber, 2-chamber, 3-chamber, and a peristernal short axis at the mid-level. Now, it is worth noting that a peristernal long axis can be used in substitution for an apical 3-chamber. However, at the Atlanta campus, what we have learned and historically been doing is using an apical 3-chamber as a substitute for the peristernal long axis for a couple of reasons. One, when you're already in an apical image for a 4-chamber, a 2-chamber, it is actually quicker for you to just simply rotate counterclockwise to a 3-chamber versus taking the probe off of the patient and then going to find a peristernal long axis. So in essence, when patients coming off the treadmill, it's actually quicker and more likely to gather more information rapidly using an apical 3 instead of a peristernal long, and acquiring the data with a higher heart rate. The second piece of information, or why we do this, is because using a true on-axis peristernal long axis, you should not actually see the apex when you're on axis and perpendicular in a true long axis. However, when you use an apical 3-chamber, you actually will then be able to add additional information, including the apex, so you're actually gathering more wall segments for assessment. The third reason in which we strongly encourage the use of ultrasound enhancement agents, and I would say at the Atlanta campus, I would say somewhere around 98 to probably 99% of our stress echoes get an ultrasound enhancement agent as a part of a routine stress echocardiogram. And the apical images tend to look a little better when utilizing ultrasound enhancements versus your peristernal. So 3 reasons in why we decided as a entity to use the apical 3 instead of the peristernal long axis. So see, in here is an example of our resting diastolic assessment for a patient. So you can see up here at the top left corner of each individual view, it tells you what phase is that we're in, which is all resting. And then underneath that, it actually will tell you what you should be doing in terms of what images you should be acquiring. So here in the top left, you can see this is the resting mitral valve pulse wave inflow. Next to that, you can see the resting lateral TDI. Below that is the resting medial TDI. And then finally in the bottom right corner is CW of the RVSP. Now note here, this particular patient did not have a clean signal for an RVSP, and that, is common. The other thing you could potentially attempt is to come back after you've acquired your apical images of the LV with your ultrasound enhancement agent. You can then attempt the RVSP signal one more time with the use of that ultrasound enhancement agent to see if it can intensify the signal. In the measurements, as we said before, looking at the E/A ratio as well as the deceleration time, looking at your medial and lateral E primes as well as your E to E prime ratios, and then if we had a signal, we would look at your TR velocity. So these basically, including the left atrial volume that we measured at the baseline, these are the major things that the ASC has identified that should be done in normal situations for the assessment of diastology. Now, we've gone through, we've done our baseline resting images, diastology, as well as our apical 4-2-3 and short axis. Patient then decides to get on the treadmill. We proceed with the exam. Patient has exerted themselves to their maximum effort. And there needs to be a great communication between you, the patient, and the nurse as to determine when the patient's going to come off the treadmill. One, so you can be prepared and ready, as well as so you and the nurse can decide when you both appropriately feel the best time to give that same ultrasound enhancement agent while the patient's walking on the treadmill, so that way when they dismount and get back in position on the stretcher, the ultrasound enhancement agent is still there circulating, and you get the same quality of images that you got at rest. So images ideally want to be acquired within the 60 to 90 second window from when the patient dismounts off the treadmill. You ideally also want the images acquired at 85% of their maximum heart rate. So what that also means is, again, the communication between you, the patient, and the nurse. You ideally want the patient to exert themselves enough to reach 100% of their maximum heart rate. Their maximum heart rate is determined based upon their age. It is simply 220 subtracting their age. That is their maximum heart rate. Then if you times that by 0.85, that is 85% of that maximum heart rate, which is the minimum ideally that you want your heart rate at when you're acquiring your peak images of apical 4, apical 2, apical 3, and peristernal short axis. So we've acquired all of those. We are going through and we're selecting the images, the multiple images that we like of each individual view. During that time of selection, we are basically allowing the patient's heart rate to come down blood pressure to come back down. And for the recovery images, we ideally want to wait until that heart rate comes down to around 100 beats per minute. Then we will initiate again. These measurements should be built into the system and into a protocol. Your first measurements would then be the same as your baseline resting images, with a pulse wave of the mitral valve inflow, measuring the E and A and deceleration time, as well as tissue Doppler of both the lateral and the medial annuluses, again measuring that E prime velocity to then calculate your E to E prime ratio. And then CW one more time of the peak velocity for the TR signal. And then it's worth noting that this question has come up several times, but all of these measurements can easily be made even in the presence of an ultrasound enhancement agent. However, you want to take careful note that many times when you use the ultrasound enhancement agent during these Doppler measurements, that you will likely have to turn your gains down or optimize the Doppler signal. From there, you will then likely have to give a little bit more of an ultrasound enhancement agent to then finalize your apical 4, 2, 3, and short axis images. Again, substitutions can be used for your apical 3. And then here's an example of, again, showing our recovery diastolic assessment. Looking again, you can see at the top here shows recovery, showing the stage that we acquired. And then each individual view is labeled appropriately to tell you as the sonographer what it is that you need to be acquiring. And you can also see here that with the use of the enhancement agent, we still got clean and clear signals of Doppler to be able to measure our E and A, as well as our E prime and E prime to calculate the E to E prime. Of note, it is worth making note that you want to ensure that your machine is not averaging the baseline E to E primes with your recovery E to E primes. What you're essentially looking for, comparing your baseline or resting E to E primes to your peak slash recovery E to E primes, is if there is a rise in the E to E prime that is significant from baseline. So let's look at a quick example. Here is essentially how on the Siemens platform we have acquired a resting 4-chamber, a peak 4-chamber, and then a recovery 4-chamber. All you can see you have the use of an ultrasound enhancement agent. And then our 2-chamber going through 2 at rest, 2 at peak, and 2 at recovery. Now on the Siemens cart, and I would suggest this probably on the Philips cart as well, one thing to do if you haven't already noticed what happens when you're currently doing stress echocardiograms is when these images are then ended on the machine and sent across over to Syngo Dynamics, they tend to become a bit jumbled up and out of order. Versus when they're on the cart, they look just like this, and if you have multiple images of the same resting 2-chamber, they're all stacked on top of each other, and you can show whichever one is your ideal best image. So what we've decided to start doing is showing on the cart just like this in the review mode and acquiring this image in review as one solid image. So that way, even if all the images do cross over, which they will, when they get over there, the physician reading can at least look at this image just like they were to look at it on the cart. Makes it a little bit easier for you and the reader to review these examples. Here's again our 3-chamber, the resting, peak images, and recovery images. And a short axis at the mid-level, again rest, peak, and recovery. And then just like we did for the LV ischemic workup, showing it in review mode on the cart, we would then look at our lateral and at rest and recovery, comparing the E to E prime. Again, I would suggest in the review mode on the cart to acquire this as a still frame image to be able to compare very easily. both the lateral, the medial, as well as your RVSP and mitral valve inflow. Now, one thing is worth noting also on the mitral valve inflow, and why in the recovery phase we ideally want to wait for the heart rate to come down to as close to 100 as possible, is because in tachycardic situations close to this patient here, the E and A start to become fused, and it can be very challenging to differentiate what's E and what's A. Same can be said for the tissue Doppler. So it's worth noting that is really the reason we want to wait until ideally they come down to about 100 beats per minute. Now sometimes you can sit and you can wait for several minutes and that isn't going to happen, and at that point you may just want to go ahead and acquire what you can. General rule of thumb of the same with the dobutamine, as we'll talk about, after about 5 minutes into recovery we would just go ahead and acquire what we can. Now let's look at the dobutamine stress echocardiogram. A little more straightforward on this. Still using the same contraindication screenings as we talked about before on anyone who has not had a full echocardiogram or at least a limited echocardiogram within our system a year previous to date. So the resting images for the dobutamine 4-stage ischemic workup start with the left ventricle, using a 4, 2, and 3 apical images, as well as a short axis at the mid. Again, you can use the peristernal long as a substitute for the apical 3. Would defer back to the same situation as we talked about earlier as to why we use an apical 3 over a peristernal long, and again would highly encourage the use of any ultrasound enhancement agents for majority of your stress echocardiogram studies. The next images that you would then acquire would be your low dose images. These images are again taken of the left ventricle. They should be ideally acquired at the end of the 10 mic infusion. Again, low dose, so 10 mics is what we're starting with. So we'll give the medication a little bit of time to actually do what it's supposed to do, which is an inotropic response. And we'll acquire the same 4, 2, 3 apical chamber images, as well as a peristernal short axis at the mid-level. After that, we will wait until the heart rate has reached 85% of its maximum heart rate. Again, you can see the formula here that we discussed earlier to determine what that 85% is. And once we have once we've reached that target heart rate after the infusion of 10 mics, 20 mics, 30 mics, 40 mics, or however many it takes, with or without the addition of atropine, we would acquire again an apical 4, 2, and 3 chamber, and then following that with a peristernal short axis at the mid-level. It's worth note that each stage we should be using ultrasound enhancement agent, so that way we can assess for clear endocardial and wall motion abnormalities at each individual stage. And then the recovery images, again, are the same situation for acquisition. We acquire an apical 4, 2, and 3, peristernal short axis at the mid-level. Ideally, you would want to wait to acquire the recovery LV images until the patient's heart rate normalized back to whatever it was at rest. However, many situations with dobutamine, it takes several minutes for that to actually happen. The compromise of what we decided to do in these situations is wait 5 minutes into recovery. If at 5 minutes into recovery the patient's heart rate has not normalized, you would then go ahead and just begin to acquire your LV acquisition images regardless of what the heart rate may be. So let's look at an example of that. So here in this case you can see the baseline 4 chamber, the low dose 4 chamber taken just after 10 mics, and then the peak images of the 4 chamber, and then recovery images taken 5 minutes or so after. And see, in this situation, our baseline heart rate was about 67. After waiting about 5 minutes of recovery, our heart rate had not normalized just yet, but we went ahead and started the acquisition. The reason we take recovery images for both the exercise and the dobutamine is rather important because we want to see if ischemia happens at peak. We want to know how long into recovery that ischemic event is still lasting. The longer that the ischemic event or the wall motion abnormalities still persist into recovery implies to the provider that this patient may need to go to cath sooner than someone who may normalize rather quickly. Look then at our 2-chamber images: baseline, low dose, peak, and recovery. Again, apical 3-chamber, same thing: baseline, low dose, peak, and recovery, all with an ultrasound enhancement agent. And baseline, low dose, peak, and recovery of the short axis. It's worth noting that at none of the phases of a normal ischemic dobutamine workup is Doppler required as part of the protocol. Only Doppler that will be done for dobutamine ischemic workup is potentially done at the very beginning before you initiate the protocol as part of the contraindication screening. There is not a diastology workup that should be done during a dobutamine because dobutamine doesn't necessarily reflect normal physiological changes that happen during exercise. It's almost over, I promise. The final thoughts is a lot of this information came from the relatively recent published ASE guidelines for stress echocardiogram of ischemic heart disease. I believe this may have been published back in 2019. This is available to anyone on the ASE's website, regardless of if you are a ASE member or not. You can just log on to their page on your mobile phone or on the computer, go under guidelines, and you can find all of their guidelines, which I would strongly encourage you to read through sections of this. And I would like to thank you for your time, and again defer any questions that you may have either to your technical director at each individual entity or your medical director, and also Teresa Green, our system educator. Thank you.